Hello, I'm Mike Wolfe. I am going to talk today about research we have been doing on awareness of health change and association with health outcomes following bariatric surgery. This is research that we've conducted in collaboration with Todd Williams from Grand Valley State, Elizabeth Dewey, and Bruce Wolfe from Oregon Health and Science University. Patients are frequently asked about health change in both clinical and research contexts. For example, in a patient intake questionnaire, patients may respond about the time course of disease or symptom progression. In research contexts, patients may respond, for example, to the lifetime prevalence of disease that has been experienced by them. And to report on changes in health, patients must first assess current health, then recollect a memory of their health status from a particular point at a previous time that is being asked about, and finally compare the current and recollected health. The potentially problematic aspect of this process is the recollection of memory of health from a previous point in time. We know from a lot of research in other domains that following change to various aspects of ourselves, people often have inaccurate recollections of their past self, and in particular, recollections of their past self tend to be biased towards aspects of their current self. So, for example, in original work on attitudes and emotions, whether it is manipulated or change over time, people often inaccurately recollect their previous attitudes and emotions, and they are recollected as being more similar to their current attitudes and emotions. There's also work in the health domain with variables such as pain and mental health. We're also interested in awareness of change in behavioral outcomes. In most studies that look at metacognitive judgments of change over time, they do not relate the relative accuracy of metacognitive judgments to behavioral outcomes. There are, of course, a lot of exceptions in the comprehension monitoring and meta-memory literature in which metacognitive judgments predict behavioral outcomes in terms of study decisions. However, in the health literature, we were not able to find any studies in which awareness of change of health over time was associated with behavioral or health outcomes. So that is something we are interested in. So the questions that we want to address are, first, whether patients are aware of their health changes when they experience a change in health. Second, whether awareness of change seems to be stable among individuals across time or whether that is variable. And finally, whether differences in awareness seem to be associated with health outcomes. In order to assess awareness of change, it is necessary to experience some notable or noticeable change in health. And the reason for that is that if prior health and current health are the same, then an accurate recollection of previous health cannot be distinguished as accurate recollection from the possibility that the patient is merely assessing current health and assuming health has not changed. And under normal circumstances, year-over-year health for most people doesn't change very much. One population that does experience significant health change are patients following bariatric surgery. We were fortunate to be able to collaborate with researchers who conducted the longitudinal assessment of bariatric surgery, or LABS. This was a 7-year study in which patients underwent bariatric surgery and then completed annual assessments every year for 7 years in which they filled out behavioral questionnaires and medical tests. The primary measure of interest in the LABS study was weight loss and maintenance of weight loss across the 7 years. We are also interested in the self-report data from a measure called the SF-36, which is commonly used in medical research. It's a self-assessment test of physical and mental functioning. To give you just a little bit of a sense of the health change in weight following bariatric surgery in the LAB study, this is one bit of data from the LAB study. So about 3/4 of the patients underwent gastric bypass surgery. The percent weight changes on the y-axis. You can see that in the first year, patients lost on average 34% of their body weight following gastric bypass. Following the gastric band procedure, which was 26% of the patients, they lost about 15% of their body weight. Following the first year, there were two noticeable trends in both groups. One, sustained maintenance of weight loss over the 7-year period, and also variability across patients in which some people gained some weight back, others continued to lose some more weight. So significant health change in this group. In order to assess awareness of change, we used a health change perception question. This is a question from the SF-36. So patients responded again yearly for 7 years. Compared to 1 year ago, how would you rate your health in general now? And the responses range from much better to much worse. And this is just the health change perception. So this is not yet grounded in actual health changes. But to give you a little bit of a sense of the descriptive data on this health change perception question in the lab's data set, in the first year, as you can see on the left, a large majority of patients reported that their health was much better than it was pre-surgery. In the second year, still quite a few patients are reporting that they are better. By year 3 and out to year 5, about 50% of patients are reporting that their health is about the same, with the other 50% a mix of reporting that their health is better or reporting that their health is worse. We are going to compare the perception of health change with actual change in self-reported health. And we get this measure also from the SF-36. This is a measure composed of a lot of questions called the physical composite score. The physical composite score does not include the perceived change question that I showed before. Here are a few sample items. They are questions about physical activity and the limits on activity. For example, to what extent is your health limit vigorous activities or moderate activities, lifting things and things like that. So the physical composite score is scaled from 0 to 100 with a mean of 50. And for each year, we calculated a change score, which was the difference between self-reported health in a current year and self-reported health in a previous year. So it's important to keep in mind that in the physical composite change score, there is no metacognitive judgment of change from the past. This is only an assessment of health at the moment, and so we can track year-over-year changes in actual self-reported health with the physical composite change score. We combine the perceived health measure and the physical composite change score to create a measure that we call concordance, which is the correspondence between perceived and actual self-reported health. In order to calculate concordance, we capitalize on a concept that Norman and colleagues described in a series of review articles called clinically meaningful change. Norman and colleagues found that across a wide number of health measures, including the SF-36, a noticeable or meaningful change was about 0.5 standard deviations difference in health status. So we combine the clinically meaningful change with the perceived health change to come up with concordance in the following way. I'll give you a couple of examples of this. So suppose a patient in particular reports that their health is about the same as it was the year before. We consider that patient to be concordant if their physical composite change score is within 0.5 standard deviations in either direction of the 0 point. There also are two ways in which a patient can be discordant. On the right-hand side, what we refer to as discordant negative is a situation in which the patient's perception of health change is more negative than what we would expect given the actual year-over-year change in self-reported health. So if the self-reported health change suggests that the patient is getting better, but they report that they're about the same, we refer to that as discordant negative, meaning that their perception is more negative than their actual change. On the other side, patients whose year-over-year health suggests that they are worse, if they report that they are about the same, they are then discordant positive, meaning again, their perception is more positive than we would expect based on their year-over-year health change. If a patient reports that they are much better, then they are considered concordant if their physical composite change score is greater than 1 standard deviation. Otherwise, they are considered discordant positive, meaning, again, their perception of change is more positive than we would expect from their year-over-year actual change. Finally, if somebody reports that they are somewhat worse than the year before, they would be concordant if their physical composite change score was between -0.5 and -1 standard deviation. Otherwise, they are discordant. So to look at frequencies of our measure of concordance by years following surgery, this is 5 years worth of data. What we can see is that in the first year, 50% of patients are concordant. In years 2 through 5, less than 50% of patients are concordant for an overall mean concordance of about 41%. Those who are discordant are a mix of discordant positive and discordant negative. And so this suggests that overall concordance, meaning the correspondence between perceived and actual self-reported health change, is not very much in alignment. And we're also interested in our second question in the relative stability or instability of concordance. So for this, we look at a patient for any particular year. Does their concordance status for the next year carry over? Is it the same or is it different? And what we find is that more than 50% of the time, consistent across years, a patient's concordance status in one year is different than that patient's concordance status in the next year. So the data suggest overall a fairly high degree of variability in concordance, meaning the patients who are, for example, discordant positive do not tend to be discordant positive across all years, but rather is characterized by a fair amount of instability. Finally, we're interested in the association between concordance and the primary outcome measure of interest in the lab study, meaning body mass index. So this is now body mass index on the y-axis, which is a combination of height and weight. And what you can see is that the body mass index varies as a function of concordance status. In particular, discordant negative patients here show a higher body mass index. So remember, discordant negative are patients for whom their perception of change in their health is more negative than what we would expect based on their actual year-over-year self-reported health. And remember also that the variability across in patients across years is fairly high, so it's not necessarily the case that these are the same patients year over year who are discordant negative. We also looked at the association between concordance status and BMI in a multivariable regression in which we predicted BMI using concordance status and a number of important clinical outcome measures from the lab study. And in this model, over and above the extent to which these clinical outcome measures explain variance in BMI, we find that both discordant negative and discordant positive patients are significantly different from concordant patients in the directions that you would expect. The discordant negative patients showing higher BMI, the discordant positive patients showing lower BMI. We interpret these results in terms of the fluency hypothesis in memory research, which suggests that when patients try to access a recollection of their past health, they're not able to directly access a memory representation from a previous time. Rather, that memory is reconstructed and can be potentially biased by information that is salient or available in the context at the time that the information is recalled. Remember, this information is recalled in the yearly health assessments, and we think this fluency hypothesis is at least consistent with the pattern of data that we found, namely a relatively low incidence of concordance between perceived health change and actual self-reported health change, and also that the concordance status is variable across years, suggesting that just variation in how the patient is feeling or the context at the time of recall could lead to both the low incidence of concordance and the stability across years. Finally, we found that body mass index was associated with overly positive or overly negative change perceptions. And to our knowledge, this is the first evidence of metacognitive monitoring of health change being associated with health outcomes. So we are interested in future research to examine this in more detail. Thank you.